Hi, everybody. This is Erica Mello, and welcome to episode number 185 of Tough to Treat. And before I get into the quick intro here, if you are listening to this live, it will be airing on Thursday, November 2nd. If you are a New York City physical therapist or a physical therapist assistant, and will be in New York City on Wednesday, November 8th, I am teaching a 2-hour, about a 1.5 hour sort of short course on decoding the complex patient. And for those of you who have taken my course before, this is mostly new material, but it's going to be sort of a short lecture course for the New York Physical Therapy Association. So if you're around, would love to see you. And if you just pop on my Instagram, you can see the link to register, and we'll just put it in the show notes here as well. So on to the episode. So this is a short week for us, and I am up for this one. And I know Susan and I talk a lot about GI dysfunction and how, it relates to patients' regional drivers and how important it is to really screen for that. And in this particular episode, I wanted to talk about, when do you actually treat directly the viscera? When do you treat the GI system? As physical therapists could do, right? Or when do we do abdominal massage? When do we actually do some visceral work? I've taken some courses with the Dural Institute on visceral mobilization. When is the viscera the driver or the primary driver? It could even be a secondary driver. And I talk about a couple case studies of patients of mine where indeed they were secondary drivers. So hope you enjoy it. And Susan and I would love to really get more testimonials I know we keep asking for testimonials, but we just love reading them, and it really helps the algorithm and for wherever you listen to podcasts. So, if you've been listening to us for a while, or if you're a new listener and have found value with our content, we would really appreciate it if you could go on wherever you listen to us and write a very short testimonial review. It could be 2 sentences. We would appreciate. We love reading them. They really mean a lot to us. And for those of you who are going to be at CSM in Boston in February, we will be speaking there. Right now, we are tentatively, hopefully, permanently speaking on Thursday, and look forward to seeing you all there. So enjoy the episode. Hi, everybody. This is Erica Mello, and welcome to number 185, our episode 185 of Tough to Treat. And as I mentioned in the intro, this is on the viscera, mostly the GI viscera. And Susan and I, as I mentioned earlier, really talk a lot about GI dysfunction. Who hasn't had GI dysfunction? Who does not have GI dysfunction amongst our patient populations? I would say 90% of my patients have some form of GI dysfunction, GI issue, however you want to call it. Some people just have significant abdominal bloating. Some people just feel nauseous after eating. Some have true diagnosed ulcers, right? Some have, a syndrome we call irritable bowel syndrome, right? There are a lot of people who have GI dysfunction, and they're, especially in all the population that we all see, a lot of them have been on non-steroidal anti-inflammatories, okay? And we all know the GI bleeding issues with the chronic use of NSAIDs. So, if that's not one clue to screen for GI disease in your patients, I don't know what is. I mean, anybody who's been on long-term steroids or long-term medications has to be screened for GI dysfunctions, Okay, so right then and there, you should start going down your review of systems and your systems review from your differential diagnosis background, right? So as always, I wanted to bring up a couple of patients of mine who have had GI issues, and they've had surgeries. Okay, so because they've had GI issues. And so one of my patients, I think she's in my course. She had chronic low back pain on her right side. I would say that with persistent, had been around for a really long time. and she'd seen pelvic health therapists, and they thought it was coming from her. They thought her driver was her pelvis. It was not. It was her neck. But this episode is not about how I found her driver. Okay, in her past movement, her past medical history, she had laparoscopic surgery for I don't remember, this was a while ago, but it wasn't ulcer related. She had a lot of, I think she had some gallbladder issues. She also had a hernia repair, but she had also appendix rupture. So there's a lot of intervention in the abdominal cavity. So whenever you hear that in somebody's history, you have to sort of think, okay, well, let's say they're coming in with low back pain, or they're coming in with hip pain. You sort of have to have that on your differential, on what I call your magnet board, right? Even if you don't know how to actually do some of the visceral mobilization techniques that I've learned in the dural courses, you at least know that you could figure out if there is an issue. And you can do abdominal massage. There's many things that you can do. Okay. However, what the purpose of this whole little short episode is, when do we actually treat it? Directly with manual techniques. Okay. So this patient of mine, as I said, she had right-sided low back pain. Long story with her symptoms. She had, I would say, the surgical procedures I just mentioned were probably at least 5 to 10 years prior to her seeing me. And she also had a history of bloating, okay? And so I treated her driver, which was her neck. Long story on how I found her driver. I think she's actually also in my book, Why Do I Hurt? But suffice it to say, her neck was her primary driver. Her cervical spine, I treated that. I got her 80% better. And there's a couple of other episodes here that we've talked about, on why your patient plateaus, what to do when your patient plateaus. There's probably a secondary driver. So this is what happened. We got her 80%, and she was like, I just still have it when I sit down at the end of the day. It still comes and goes occasionally, and I'm like, oh my God. And so I went back and went over her medical history, and I was like, there's got to be something in her abdominal cavity, surgical scar tissue, however you want to call it, that could be responsible for her low back pain. We all know the direct connections with the GI system and the lumbar spine, right? There's just so much tension in that system that can affect your lumbar nerves, and your sacral nerves, right? Even your lower extremities, and I'll get into that one in a second. So what I ended up doing, you did your abdominal palpation. I didn't auscultate. I didn't take a stethoscope, but you can, palpate the abdominal pulses without getting into all the dural stuff. I think they're very worthwhile courses. I've taken VM1, VM2, and the general listening course. It just gives you an idea. It opens your mind to other options, right? Because I will tell you that I went in and I found some restrictions in her, just even her soft tissue. Forget even going into the viscera. Her abdominal cavity was really tight and toned. And she wasn't doing a lot of sit-ups. She wasn't that kind of a person, right? We call them abdominal grippers. So I went in and I just did some basic myofascial soft tissue work into her abdominal cavity. And I can get into this on another episode, but I went there. I didn't do like a psoas release. I actually went in and did some, skin rolling, some slackening of the abdominal, the rectus abdominis, the external obliques. I went lower. I did some horizontal massage. I did vertical, and she she was actually improving. And so if you think about, even with constipation, when you could have stored bowel contents in the system, that will affect your lumbar spine, right? It really will. So doing any kind of mobilization and motility work will generally help in the long run, okay? But with her, because of her history of surgeries, don't discount a laparoscopic surgery or a hernia repair, okay? There's going to be scar tissue in there. And I did a lot of those techniques in sitting, where I could get under the diaphragm and just do some, just nice mobilization in there. I had her do some thoracic rotation in sitting. I had her on her side, going in from the side into the abdominal cavity. I had her on supine with legs over a bench, tabletop. There's many ways you can treat this, okay? But my point is how do you know, when the viscera, when you should treat it? This particular example, it was because I got her 80%. She had it in her history, and I was trial and error. Okay, if I treated her viscera from the beginning, she wouldn't have gotten 80% better. It wasn't her driver. It wasn't her primary driver. So there's some really, some pretty interesting clues in the patient's narrative that you can use that will clue you into, at some point, possibly screening, or not even screening for GI disease, but looking for it when the patient's plateaued, at least in this case. Okay, so obviously if the patient's coming back in to see you, and they've had a lot of NSAID use and they're chronic abusers of that, then that's definitely a clue to screen for GI dysfunction. You're obviously going to screen for GI dysfunction when they say, oh, after I eat food I don't feel great. That's a GI related issue, right? There's a couple of other things here that I think that would be important. When someone has back pain or abdominal pain at the same vertebral level, you need to start thinking that maybe that there could be some systemic issues with your patient, especially if they're accompanied by constitutional symptoms, like fever, nausea, vomiting, things like that. And I think a couple of other ones would be, this is quite an interesting one, is if someone who's coming in with multiple joint pain and arthralgia, and they have had a lot of skin issues. That is also a clue for screening for GI dysfunction. So those are just some real clinical pearls as to if my patient has low back pain and I've gotten her halfway, but she's got a lot of GI dysfunction and she's had a lot of surgeries to the abdominal cavity, then maybe I need to go in and determine if the abdominal cavity or the viscera is the driver. And a lot of these patients have their abdominal they're so tight. Even just slackening up some of the tissue there, and even just basic breathing on all fours and let the abdomen hang really helps a lot of these people, right? They need to let go. Okay, so this patient, I've treated her viscera, and she says to me at the end, "Erica, that's what got me better. I can't believe it. You went in and you did my work in my tummy," and I'm like, "Oh my God!" But it just goes to show you. I mean, she really was hanging her hat on that, and so don't miss this, because it is becoming much more increasingly common, more common than you think. My other last example is a patient I saw last year, and she had some bilateral leg pain, pretty significant, and it only happened at night. And it wasn't like in the middle of the night. It was like at the end of the day. She lay down, and her leg pain. It was diffuse leg pain, non-dermatomal or myotomal related. Anterior, posterior, whole leg. Had been scanned and screened, and I was once again like the in a long line of therapists that she saw. So she also had abdominal surgery. Okay, she had a laparoscopic issue she had actually an ulcer, and she also had two hernias. A lot of the hernias are very important. That scarring can really be a secondary issue in some of your patients' presentations. So I think that the clue there is in her history, right? I mean, someone's coming to see you and they're not getting better with direct treatment or other types of treatment. There's got to be a way. There's got to be a reason why. And you think about it. Someone has no symptoms during the day, and when they're lying on their back in a supine position, their abdominal contents are pushed up into their diaphragm. And it could be impinging on bilateral lumbar or sacral nerves. She had bilateral symptoms. That always raises a red flag, right? Diffuse symptoms raises a red flag, right? Once again, not postural related except for supine lying. But think about what happens to the abdominal cavity in that position. My differential diagnosis after doing my evaluation or my magnet board was either it was a neuropathic, more of a dural issue with an abdominal or a visceral secondary driver, or a visceral, we call it like an impairment, like an abdominal gripper. Yes, she had GI dysfunction, but she also had the surgery. So I want you to think about that. And I know I brought up the two patients here that had the surgery. Don't be afraid to go into the person's abdominal cavity and do some assessment if you feel comfortable with that, okay? You can assess tissue and tone for transverse abdominis, external, internal obliques. You can assess their breathing patterns. Those are indirect ways of treating the viscera, right? need to take a course on this, but I think you should. They're great techniques to use. But my point is that you want to be aware that this region of the body, I'm talking about the abdominal viscera, it can be a potential driver. Okay, you just don't want to, say, well, I don't know what else to do, or you could refer them on to somebody who does this, or you can just do some basic, honestly, skin rolling in the abdominal cavity, abdominal massage. That all really helps. It really does. And with this particular patient, I actually did end up doing. She had what we call a dural driver, so I did a lot of dural techniques with her in many positions and treated her abdominal cavity as well, and worked on that. Because if you think about the dural tube, if there are any adhesions from any kind of abdominal surgery, that could, impair the mobility of the nervous system. And, once again, you look at these cases, obviously on a case-by-case basis, because these are tough patients, but you're looking at their whole history. If the patient says to you, they come in with knee pain, for example, and then you do their history, you do their systems review, and you're ready to go with your exam, just ask them. I always mention on our podcast, I always say to the patient, if there's anything else that I haven't asked you that you want to tell me. I would also suggest that you ask, are there any other symptoms anywhere else in your body that could even be unrelated? Or do you have any other symptoms in your body? And they may say, oh yeah, I know, I get a lot of nausea and bloating. They would never mention that to us because they don't think we can help with that. So you may want to just ask that, are there any other symptoms anywhere else in your body that may or may not be related? And they'll be like, well, yeah, I have this, this, and this. And that's when the radar's going to go up. That's when you're going to start to really, that's the money shot in a way, the money, that's really when you're going to start to say, oh, okay, well then maybe this is the driver, or this is an issue. So you'd be surprised at what patients actually ask. So, I hope you enjoyed the episode. It's definitely one for, I think, a long one that Susan and I should do. It's becoming much more popular now. But, once again, if someone has had appendicitis attack, gallbladder surgery, any kind of abdominal surgery, I think you really should go in and screen for restrictions of mobility, of soft tissue there at the very least. I know we can all do that, okay? And then you could start screening any other, for any kind of GI issues. If you feel uncomfortable doing that, you could always refer them out to a nutritionist. But I think that we have in our skill set, we have the knowledge to ask these questions, and just know your referral patterns, right? Know the referral patterns. I mean, the gallbladder is going to probably refer to the right scapula. I had a patient years ago. She had horrible scapular pain. Nobody knew. Nobody could figure it out. And then she had her gallbladder removed and it went away. So, I'll never forget that. Liver also refers to the right side, right shoulder, upper traps. Know the referral patterns. Go back to your differential diagnosis book. Know the referral patterns for viscera. So it'll save you and your patient a lot of time if indeed they actually need their gallbladder removed, because it does refer in sneaky ways. Anyway, enjoy, and we'll see you on the next episode. Bye.